Arul, you can ask a lot of questions.
How do you said something?
So, Sashi, you are live now.
Okay, thank you. Good day, everyone. Welcome to another session of the Indian Cartilage Society webinar series. Today we have a wonderful person, a good mentor and friend, Dr. Santosh Sahanan, past president of the Indian Cartilage Society and senior consultant arthroscopy surgeon from Ortho One Hospital, Coimbatore. Dr. Santosh is going to talk about the subchondral bone. Before that, I would request Dr. Santosh to speak a few words about himself.
Yeah, very good evening all. I thank Indian Cartilage Society for the opportunity, especially Rajat and Dr. Navaladi, President and Secretary, and the Education Committee as Sasinder and Sumit has been organizing, and Arul with the EC members doing a great job of organizing such academic events. It's great to be here again. So, shall I share the screen?
Yes, I invite Dr. Santosh to talk about role of subchondral bone response in the success of marrow stimulation techniques. Over to Dr. Santosh.
Yeah, is my screen visible?
Yes, clear.
So, talking about subchondral bone, it's a very, very good topic. And do interrupt me in between. Let's have this as interactive as possible so that we discuss more than just being a lecture. So I've tried to keep this more clinically relevant and just touching upon the basic science. If I go into the details, which I'm not really aware of, just based on the literature, if we go into the details, it's going to be boring and it'll be over our head. As orthopedicians, we are not well versed with such basic concept. So, in brief, as you know, a cartilage, we used to compare a cartilage to more biological healing. It's not like just filling up a pothole on the road. It's more like a growing grass again. So for that, for growing grass, the underlying sand or the field is more important. So the roots and the underlying subchondral bone is compared to the soil. So it's more biology. It's cartilage is a substance which is not like a liver, which has a very good capacity to regenerate. Unlike liver, cartilage has very poor capacity to regenerate. That's the basic thing which we should understand when you are dealing with cartilage reconstructions or recovery related issues. So marrow stimulation technique. So you know what subchondral bone is. The bone which is below the tide line is called the subchondral bone. So marrow stimulation techniques, which is a common technique, is a microfracture, which involves creating access channels, which might be pegs, which might be drills, or it can be just a debridement of the overlying calcified cartilage layer. So you just create access from the subchondral area where bone generated cells are eluded onto the outer surface and which are led to set and form cartilage. This is the basic concept of marrow stimulation technique. So the literature is so varied that in the marrow stimulation techniques, the results are so varied. But the basic concept is all these techniques do give healing and it forms a fibrocartilage, type 1 collagen. Unlike in hyaline cartilage, fibrocartilage is not so stable and strong to take the load longer time. A lot of debates are there. And regarding the technique, the first and basic foremost technique is to remove the calcified cartilage layer. Without removing this calcified cartilage layer, whatever tissue forms over it will not get integrated with the subchondral bone. You can give access to the subchondral bone only if you remove this calcified cartilage layer. And this marrow stimulation historically was done with the peg holes with these awls, which are around 2 mm width, and the depth of around 3 to 4 mm should be reached, and the gap between them must be at least 3 mm. And this should not be washed out, as the fat cells and the marrow cells which come out has to stay over there. And as it forms a clot over there, post-op, you need to give good range of motion where shear force is good for cartilage healing, but at the same time, compressive force loads might not be very useful in the early phase. So initially, rehab should be non-weight bearing depending on the area of the lesion, the location of the lesion. Then partially loaded and full weight bearing as the cartilage heals. The duration depends on the location, size of the lesion in the area of the joint, whichever you're dealing with. But why this has not been very successful is because of such complications. There is chances of changes in the subchondral bone, like sclerosis of the bone. There is chance of intralesional osteophytes, which is overgrowth of the bone and overgrowing the level of the cartilage, which thins out the overlying cartilage. And cyst formation is another complication of this. Indications have been conventionally usually small size defects, because fibrocartilage for a larger size defects will not yield good results. And lesser age, smaller defects, lower BMI, and femoral lesions do well better than tibial lesions, which do well better than patellofemoral lesions. Those have been the results observed over the years. As I've told, the fibrocartilage forms stays good probably for a few years. As the years progress, the results of this microfracture technique goes down. There's a very good paper by Mithofer et al., which clearly states that after 5 to 7 years, the results of these microfractured fibrocartilage wears out, and the outcomes are better. Short-term outcomes seems to be better than the long-term outcomes. And when there is microfracture done, any procedure done after a microfracture, the results of resurgery have been poor. So as a first procedure, if you can avoid a microfracture and do something else, it will be better. If you're not planning for any other procedure, then you can go ahead with a microfracture, specifically in a smaller size lesion. So what has been the thought process of microfracture? This is one good article by Jack Bird, which he claims there is no clear-cut difference or clear advantage of microfracture over debridement alone, which is just a chondroplasty, shaving of the superficial calcified cartilage. And he claims that why we should be doing it's just a commentary, level 5 evidence, and he claims that microfracture is actually have more complications than abrasion chondroplasty. Then there were a few more articles on going forward with microfracture. This one Mithoff has done a lot of work on this. How important is removing the calcified cartilage layer from the lesion base before you do a microfracture? He insisted on talking about it. Talking about subchondral bone, there are a lot of research gone to find out what was. It was more of animal studies, more of rabbit based studies were done, and sheep based studies were done, which compared the size of holes which were required, which they have tested all sides of holes from 0.5 to 2.5. There are results have been so varied that it's confusing, but around 1 mm size of all yields better results, 1 to 1.2 mm width of the holes. And the spacing, at least the 3 to 5 mm spacing is better, because the structure of the subchondral plate must be retained. There should not be any collapse of the subchondral bone after you microfracture. Then if there is a collapse, then the chances of bone formation is more than cartilage. And that's the reason you might have an interlesional osteophyte. So with distance between the holes, depth of the hole, which should reach the subchondral marrow area, which is around 3 mm plus, 3 to 5 mm is ideal. And the spacing between the holes all is important. Then comes these are studies which I was observing when I had a opportunity to spend time with Henning, Madry, and Magdalene, who have done a lot of research on this. And this is a paper which in a rabbit model, which had shown that just a debridement is good enough and does better than the all. I'll talk about their research in the last part of the study, which was a very useful part, which I spent some time. Then comes the landmark article, which mentions that rather than using a microfracture, all micro drilling yields better results. This is based on the concept where there is impaction. As you can see closely on the dark black image on the left side, which is marked as MF, you can see the walls have been blocked off. This is because of the impaction. This is micro CT. This is because of the impaction of the bone onto the walls, and your access to the subchondral bone and the marrow is reduced. So there is not much of fluid which comes out. So fluid is less and the marrow access is less. So the overlying formation of cartilage in the right side image is also visible here, which is poor. So now the consensus is definite. There are a lot of evidence to prove that micro drilling is much better than microfracture. So our current, I don't think more any do microfractures. All have changed to micro drilling. And the size of the drill is 1 mm to 1.5 mm. There are various studies which have come forward to prove the same. At the end of this microfracture, micro drilling rather, you can see the superclot formation, and that clot must be stable. So there are a lot of studies quoting the changes in the subchondral bone post micro drilling. So what are the changes you look for? It's a subchondral bone plate resorption, and whether there are cyst formation, and whether the surfaces are continuous and smooth, and after the drill holes, whether the drill holes heal and close, whether there is a overgrowth of the bone like an interlational osteophyte formation. All of that have been studied, and microdrilling has been proved to be superior. And this is one of the human cadaveric studies. Very few human cadaveric studies have come, and this is shown that microdrilling, there was a thought process where drilling causes osteonecrosis because of heat necrosis around the drill holes. But this study proved that that's not much of significant necrosis, which is very, very insignificant and very minimal. So microdrilling is a safe procedure to be done. This is based on a human cadaveric study. And this study is a review article. It's a very good review article, which gives a overview. If you really want to know what's the insights, you need to go through this article by Dexter CO, where they say the superficial cartilage and is good, but deeper bone changes are much more with subchondral drilling. So whatever you do, there's not much of differences in the superficial cartilage, the superficial bone, when you do a subchondral drilling compared with the non-drilled normal areas. But overall, if you can augment any other additional factors, I'll talk about augmentation later on, the results are much better than just a subchondral fracture. So this really gives us the overview of the entire talk, where bone density deep part of the subchondral bone significantly decreases to the untreated defect. So additionally, if you add biological adjuvants, the results are much better than bone marrow stimulation alone. So our techniques of bone marrow stimulation must be refined, like what size of drill you use, how deep you go, how much you space it, and how exactly you do. Rather than fracturing, drilling is better. Smaller sizes are better. 3 to 5 mm are better. So, and using biological augments increase the outcomes. So that's the way of progression in the clinical side, which we should be looking at. So there are so many augments which are there, which are scaffolds, types of cells can be added, cell signals can be added, proteins can be added, all in combinations, or scaffolds can be added. Talking about this, and you can add just along with the microfracture, using the cells, you can add hyaluronic acid. There are so many variations. I'm not going into the details of this. It can be natural, as you've already seen, chitosan, which is a shrimp extract, which can be used, or silk can be used, hyaluronic acid can be used, which can be avian based or bacterial based. Xenografts where dermis of allogenic material also can be used. Synthetic materials are available, tricalcium phosphate, ceramic, metal components are available, but they are most robust but not degradable. And composite materials are available as scaffolds, which you can augment it along with your microfracture. So results of these have been studied at the experimental level and clinical level. Very few studies are there, and still we do not have the complete answer to all of this. So the other aspect of Madri and colleagues were to explore the gene-based therapy along with this microfracture, where you add plasmid RNAs and into the defect, and this synthesizes your cartilage. And the early results of these methods have been very, very promising. So in total, microfracture has been evolving over time. Micro drilling has been the concept now to adopt. Adding biological agents have changed the outcomes of microfracture. So currently, small-sized defects in a weight-bearing area or a non-weight-bearing area are ideal situations where you can do a microfracture with good outcomes. Thank you.
Thank you very much, Dr. Santosh. It was a very crisp presentation. I have a lot of doubts. So, in your practice, what are the indications when you do marrow stimulation technique alone without matrix or some other procedure, whether be it microfracture or micro drilling? So, what are the indications that you do only marrow stimulation?
There are no micro fractures in my practice. It's always micro drilling. If you have noticed it prior in a medium-sized defect, I avoid doing this. We plan for another definitive procedure. In a higher demand patient, even in a smaller defect, I prefer osteochondral transfer. But for a low demand patient, for a small defect, contained defect, microfractures are okay. And in an elderly age group, I do microfracture even for a medium-sized defect when I notice them associated with those root tears or early OA changes in a patellofemoral joint. Patellofemoral joint do not yield good results as per the literature. But I believe the patellar defects do not heal well because our access to the patella is in an oblique direction using microfracture holes. Because of the oblique, our drill, I mean, when we use a wire, it is very difficult to pass. But I have published technique called push and park technique where we sublux the patella laterally and still drill it perpendicular. Or you can drill it retrograde from anterior surface also. With those methods, I think we can get some amount of cartilage growth. That's my belief. I not got the results of those yet. So microfracture in patella and small central defects in trochlea are ones which I still do micro drilling.
Okay, wonderful, wonderful. Thank you. So, suppose someone has to do microfracture, they don't have access to matrix substances. I'm talking about small lesions. So, what are the best way or the best instruments to do the marrow stimulation techniques, for example, microfracture or micro drilling?
So 1.2 mm KYs are the ones which I regularly use. So KYs are good enough. Getting the angle right using through the portals, you can access most of the femoral condyles. But if it's in the trochlea, you might need to go just below the patella or medial or lateral to the patella. As I said, for the patellar defects, you might need to go from the gutter downwards by subluxing the patella laterally or medially based on the location. Apart from that, if you're doing a microfracture, you need to have those curettes, fine curettes, small curettes to curette out the calcified cartilage layer before you do a microfracture. So curettes are the ones which is not the usual stuff which we have for cartilage. I mean, regular procedures. You must have these ring curettes and fine curettes to curette out the base of the defect. While curating out, specific curettes are required because your regular curettes might take away a chunk of your subchondral bone. So you should be very careful not to take away the subchondral bone. Only the superficial calcified cartilage must be removed, and the walls, the surrounding walls must be made vertical, so that this becomes a contained defect.
Yeah, wonderful. Thank you. But you just said that you don't want to impact the bone, right? So if you are using a K-wire, you are still going to impact the bone.
No, we are going to drill it. We are not going to hit the K-wire inside.
Yeah.
It's going to be
Okay.
drilling
Right.
through 1.2
Right.
mm K-wire.
Yeah.
So you're
Yeah.
not going to
Because
mallet it in. It's drilling in. You need
yeah.
to have a drill.
Yeah. Are there micro drills
Nano
like?
drills. There are the companies which come up with nano drills, which are uh, less than 1 mm. Those are specific drills, and there are flexible nano drills which can go in at angles and
Yeah, with the
but
flutes so that they take out the bone. So
yeah. So
yeah,
those are the ones which are available with various companies, but it's not really mandatory to have them in your
yeah, wonderful. So you're talking about debriding the superficial calcified layer. How do we exactly know how much is too much or where to stop?
Yeah, change in color is one thing which you can notice. It's always a challenge in a chronic case. In a chronic sclerotic bone, you will not know where everything is sclerosed. You cannot. Only in a fresh focal defect, you will be able to clearly appreciate the superficial and deep. It's from that um, yellowish layer, you come to a little orangish layer, and the feel it comes up easily. When you're scoping it, the feel of the cartilage comes out easily. It's not like definitely not like scoping out bone when you do a notch plasty in ACL or something. You know the feel of the bone, right? It's not so hard. It will be definitely softer than that, and it peels off as a layer.
Yep. Yeah. Thank you. Thank you. That was very clear. But then when it heals again with calcification with superficial cartilage, right?
Fibrocartilage, the cartilage.
But is there a calcified layer that is formed again below the fibrocartilage?
Uh, it might, I don't know whether you can term it as whether it is a calcified layer of cartilage, but the Mocart's scoring actually assesses that, and even those scorings for the biopsy histopathology assesses how is the continuity of the tide line. So hopefully, I'm not sure you can call it the calcified cartilage layer. Histologically, you need to look for the continuity of the tide line
Right.
layer. And even in the MRI, for the Mocard score, you need to look at the continuity of the neighboring subchondral bone onto this. Only if that is continuous, you will get high scores. So hopefully, I think it should be forming again, but I cannot really say whether we term it the same way.
Dr. Arul, you have some
Since Sasi
questions?
sir has asked this question, like I have a question related to this. Like post-operatively, like if you have an opportunity to go with an MRI, have you experienced seeing like a bone cyst formation or like a edema in the side where you have did this kind of bone marrow stimulation procedures?
Yeah, edema remains. Edema is there for a year, maybe even 2 years. You can see those drill hole directions, especially in OCDs, which we do retrograde drilling and drillings. We do see them for quite some time. Especially if it's an adolescent, you don't see them. It heals quite fast.
Right.
Edema, I mean, don't worry about edema for at least a year.
Okay.
It will remain for a year, so don't repeat MRI at least for a year,
Okay.
because if you see patients would come and report would be mentioning something, and so generally do not repeat it at least a year. Ideal is to do it at 2 years,
Okay.
but unless you suspect something else, and to look for healing, for looking at for the MOCAD scoring for microfractures, ideal will be at 2 years is what I would say. Then only you can have a good grading in the MOCAD score. Otherwise, your MOCAD score will be inferior.
Okay.
Cyst formation, yes, but I am not seen cyst formation with micro drilling. Reports all for micro fractures, you do see cyst formations. When you're using implants, then you can find some cysts when you're fixing certain defects. Then you can see those cysts. Cyst formation might be more common in talus and not in the femoral condyles. Talus cyst formations are more common post-op.
Okay, okay. Sir, and regarding the depth of the microfracture, like for the beginners, like they may not have the feel like how you feel. Maybe like they can see the bone marrow bubbles coming out of that. They can use that as a guide, like they have entered into the
Yeah,
marrow
yeah,
region.
definitely. But bone marrow coming out of the neighboring hole is what you see. Otherwise,
Okay.
you'll see only bone marrow coming out after you take off that wire. So when you're doing two, three holes, only if it's close to each other, you can feel when you're putting it in one hole, when the pressure inside increases, then the bone marrow comes out of the other hole. But that ideal giving way, as an orthopedic surgeon, you must know when you're going to the first cortex and the far cortex, right? So same way, when you feel that give way,
Giveaway.
almost similar to going across the
Okay.
first cortex, not
First
the
cortex.
same intensity, but that feel,
Okay.
you must know the feel, which you feel the small give way, you stop there. So you
Okay.
just need to breach the subchondral plate and go into that marrow. That's enough.
Perfect, sir. Perfect. So since we are discussing about the techniques, like you have described well about the interval between the holes in microfracture or micro drill. So do you have any specific cutoffs when we are using a nano drill, like less than 1 mm drill kind of thing you said about nano fracture?
Yeah, but the recommendation is 3 to 5 mm gap. Even if you have a nano drills, the concept is you get enough of bone marrow cells supplying your overlying tissue,
Okay.
access channels to supply your overlying tissue. So integration wise, it's just taking off the calcified cartilage layer is enough to integrate. That's why there are contrary claims where abrasion chondroplasty itself is good enough. So if you can get good cells with abrasion, with exposing vessels in the subchondral bone, it is good enough. You do not need to access the channel. This is the contrary group which claims the microfracture might not be required. So
Okay.
the number of holes and spacing is for the access of cells. So if you can have enough cells coming into that area, then it should be fine, is what I think.
So like you would say you would like to say like nano hole or nano fracture would be like more better than those that of micro fracture or micro.
Correct, because the integrity of the subchondral bone must be maintained. When you load it, it should not collapse.
Okay.
So that is more important. If there is a collapse or if there is a stress in that small micro fracture or stresses causes bone formation and not cartilage formation, then you have those intralesional osteophytes forming.
Okay.
So that's the reason probably micro fractures have higher chance of intralesional osteophytes than micro drilling.
Okay.
Drilling does not cause
Damage to the
micro fractures.
fracture.
When you have impact, it will cause micro fractures around. That causes more bone formation.
More information. Okay, okay. So good, sir. And like, how do we clinically or radiologically assess the readiness or the health of the subchondral bone? Like, I mean, before in a preoperative planning.
In the preoperative planning,
Like if you are planning for a marrow stimulation procedure, like, I mean, we need to know the underlying soil should be
yeah,
like
yeah,
quite
okay,
good
got it.
enough.
So in an MRI, I mean, this question becomes very, very relevant when you're dealing with osteonecrosis.
No.
Or probably it's a good question. Okay. Um, Take an example of a root tear. So in a root tear, you see impaction fractures in a medial femoral condyle. So there'll be heavy impaction and a lot of contusion.
Right, sir.
But the overlying cartilage might be thinned out. It might be thinned out, but there might not be loss. In those situations, do not do a microfracture because the subchondral bone will already be compromised,
Yes.
and doing a microfracture there, it's going to compromise the vascularity further. And in some situations, there might be osteonecrosis, where the signal intensity over there would be darker, like an avian. So doing a microfracture there again loosens that part further. So over there, I wouldn't advise doing a microfracture or taking off the superficial cartilage. But drilling, like in an avian, where you give access channels to the dead bone from the normal bone, might be indicated. But taking away the superficial cartilage is not advocated because that's the only thing holding it back. So you should retain the superficial cartilage and drill the underneath lying structures. MRI might report a lesion over there, but it's a stress fracture and a subchondral fracture which has made the superficial bone necrotic. That heals on its own. But if it's a chronic necrosis or osteonecrosis, you might add few drills to give some vascular access channels. Those are the things which you might need to assess in the MRI. And subcon in OCDs and things like that, then you need to look for cysts and things. When cyst is there, you need to take off the
Cyst
bone
completely.
out, and you have to fill the cyst, or you need to freshen the
So
part
those
which
kind of
was.
cases, you won't prefer this kind of marrow stimulation procedure alone, right?
You open it out. I mean that you cannot marrow stimulation only. It's like treating a non-union. You
Okay.
would like, again give in an OCD. It is a part of the bone which is sclerotic on both ends. So you open it out, freshen it like a non-union, give marrow access. Again, it is a marrow stimulation only, marrow access, and then put it back and fix it. As we are not talking about microdrilling, we are talking about marrow stimulation, so we can talk about it also. Same marrow stimulation can be used for all cases of meniscus repairs, which we do without an ACL tear. So all cases of meniscus, isolated meniscus tear without ACL, you have to give marrow stimulation. Yeah, we do drill holes or pegs in the notch area. I give access to marrow cells so that meniscus heals well. So that is again a marrow stimulation technique, but not with cartilage, with other procedures.
And of course, sir, like when you see like arthroscopically, like how the bone integrity and everything, then like, I mean, your assumption or your plan will be like meticulously planned after that, right? Like though preoperatively we have a dilemma, like whether marrow stimulation is a feasible thing or not. Like intraoperatively we can take a call.
Yeah, but if you really pick up something in the MRI prior, that means it's a significant lesion, medium size. Small lesions might be ignored, but if you're able to pick it up clearly, that means it might mostly would be a medium sized lesion. For a medium sized lesion, I would be wanting to do something else than marrow stimulation alone,
Mm.
like osteochondral transfer or ACI or some BMAC, not just a marrow stimulation for a medium size.
Okay, okay. Since you said about something about the indications, sir, like apart from size, are there any other identifiable like patient profiles, like
Months.
a BMI or I mean some sort of varus, malalignment kind of pictures or a age? So does that
So
affect your
all of those factors are important, but activity level of the patient is
right?
most important, and of course the location of the defect, whether it's exactly in the weight bearing area or not. For a petla instability, you might pick up a defect in the lateral femoral condyle, in the lateral most edge. No point addressing it with aggressive procedure. It's not going to be hindering the issue. So, but it's in the weight bearing area, you have to address it. Whether that's one thing which you need to know. Size is the other thing, whether it's contained or not. Demands of the patient. A small size defect for an athlete, I would never do a microfracture. I would still do an osteochondral transfer where you're restoring a hyaline cartilage onto a higher demand area. Same way, if the defect size is medium, I would try to do the other procedures rather than do a microfracture. All of these factors are important. Uh, it's a patient specific decision making.
Okay, sir, fine, sir. So most of the time we feel no, like when we are planning for a HTO, like when we are doing a diagnostic, we will see some kind of meniscus debridement, loose body removal. So that time, like we'll be planning for a microfracture in a 50-year-old around something like that. So in that age, like, do you really consider about the BMI or some other factors?
Yeah, it's a controversial topic, but good that you brought it up. Previously, for my experience, I'm just sharing for all HTOs, where we have raw bone exposed, right? Medial side, there will be a
Right.
raw medial femoral condyle or tibial condyle. I used to do a microfracture quite aggressively. Um, but post-op, then after some time, I stopped doing that. But I didn't find any difference at all. By doing a microfracture, actually, post-op pain was slightly higher. Because I don't know whether it was because of the microfracture or not, but post-op pain was slightly on the higher side, maybe for the first week or so. So I stopped doing microfracture, but I
And that to
don't.
that proportionate with the size of the defect, maybe, sir. Like if it is a
uh,
wider bare area, something like that.
Maybe. Yeah, maybe. So I don't do microfractures aggressively for arthritic knees, but do wider spaced out, maybe 5 to 6 mm apart, few drill holes just to give access to those marrow cells. Not
I
same.
think we have to make the clarity whether we are dealing with chondral defects or with arthritic
Arthritic.
joint.
Right,
Yeah,
sir.
so the management principle itself will be totally different for the arthritic joint in comparison to the focal chondral defect. The whole principle of microfracture should be applied only for focal chondral defects, and that is when you mark the area and see whether it is a small lesion or a medium lesion or a large lesion. still I think the arthritic knee is a definite relative contraindication for microfracture. It is already arthritic, so there is nothing that we are trying to heal in the arthritic knee, but rather by changing the biomechanics with a high tibial osteotomy, there is still a good chance for healing of the cartilage, the so-called healing of the cartilage. Possibly it does heal when you actually change or improve the biomechanics
Right.
beyond our
It's like
expectation.
both of you are expert in doing those procedures, and like suggesting like we should not I mean we should not try these kind of microfractures along with the HTO. But like practically seeing most of the surgeons like where I used to see or where I used to practice also when we are doing a HTO and the diagnostic arthroscopy or some sort of meniscal balancing or repair surgeries. So we do have a microfracture in our armamentarium. We will not be having any other cartilage procedures or things for that. So we'll do microfracture, and we believe like as you said like fibrocartilage will form. Does that is a harmful procedure? Definitely we can go about it, right? Maybe post-operatively pain. So that's the one thing, but that's only a short-term problem.
Yeah,
So
yeah,
what about the
you can.
long-term
Yeah, you can go ahead. No harm in doing it in a meticulous,
arthritic
guarded manner, not
yeah,
to be very aggressive.
aggressive? Fine,
Micro
sir.
drilling, yes, but not micro fracture.
Okay.
But
Mm.
I would like to differ because
Yep.
what you're maybe high tibial osteotomy does even better than we think when it is used for the right indications. The whole concept of aligning the knee itself is going to relieve the pain and also improve the joint. When it is already improving the joint, there is no point in actually doing a microfracture, knowing the fact that microfracture is not specifically going to heal the joint. And biomechanically, possibly microfracture is worsening the situation inside the joint. Microfracture, again, we need to clarify that it is a procedure for focal chondral defects. It is not a procedure for even large defects. Forget about osteoarthritis, which is a global defect.
Okay.
Osteoarthritis is a global cartilage damage of the joint. So let us not discuss about microfracture for osteoarthritis at all.
Understood, sir. Understood. So my final question, sir, to Santosh, sir. Sir, how does like early weight bearing versus a delayed load bearing after these kind of marrow stimulation procedures, or what about your, rehabilitation protocol following the procedure?
Yeah, one, the location of the defect. If it's the weight bearing area, it's different. It's patellofemoral, it's different. If it's in the
Okay.
weight bearing area, we'll discuss about that. Patellofemoral is totally different. Initially, and how large the defect, whether it's contained or uncontained. If it's a small defect, when you feel your
Exactly.
condyles are going to edges are able to take the load, you can partial weight bear if it's a very small defect. But if you feel the edges are wide enough where the convex area central is going to hit the tibial plateau,
Okay.
then you need to unload. So 4 to 6 weeks of unloading is required, but some amount of shear definitely gives good shape, which will stimulate the fibrocartilage formation.
Exactly.
Minimal load is actually good. So by 4 to 6 weeks, you start partial weight bearing. But full loading, I would say 6 to 8 weeks.
Okay.
Yeah, I think that's a very good explanation. We need to be very specific or customized in respect to the rehabilitation. We need to see whether the lesion is shouldered well. That means the surrounding cartilage is taking over the load. The load is not going on to the microfracture region or the bone marrow stimulation region. We should understand that what is being filled is fibrocartilage, which cannot bear weight as much as hyaline cartilage, and it cannot bear shearing forces as well. So as long as there is a good amount of shoulder area that can take over the load, it is okay to weight bear early, not immediately, but early. But if it is an unconstrained region, region where there is a lot of shear forces, for example, a trochlea where the patella engages, especially in a higher flexion. So that amount of flexion should be avoided in order to prevent shearing forces on the lesion, on the healing area.
Right, sir. Right.
Okay, I think that was a very lively discussion, short and crisp, and a lot of things to learn for every one of us. Thank you so much, Dr. Santosh, for your time. I think you can go ahead with the next presentation in the next meeting hall. And thank you so much, Arul, for coordinating this. And thank you to Dr. Rajat, the President of Indian Cartilage Society, for organizing this. See you all again later.
Bye-bye. Thank you all. Thank you very much for the opportunity. Bye-bye, Sasi.